Hello, this is Eric Strong again, and for this 10th lecture, I will be talking about metabolic alkalosis. The learning objectives of this lecture are to know the differential diagnosis of a metabolic alkalosis and to be able to identify the specific etiology of a metabolic alkalosis in an individual patient. One way to classify the etiologies of a metabolic alkalosis is to consider what the primary issues are, both which organ between the GI tract and the kidneys the problem is primarily in, and what the basic mechanism is between loss of hydrogen and gain of bicarbonate. For example, loss of hydrogen ions in the GI tract can be due to either vomiting, nasogastric suctioning, or congenital chloride diarrhea. I'm going to be talking much more about the other conditions listed on this chart in a few minutes, but congenital chloride diarrhea is a rare genetic defect in an epithelial anion exchanger which results in a syndrome of hyponatremia, hypokalemia, and metabolic alkalosis, usually presenting immediately after birth. Conditions in the kidneys which can result in loss of hydrogen include loop and thiazide diuretics, Mineralocorticoid Excess, contraction alkalosis, and Bartter and Gitelman syndromes. In the gut, gain of bicarb can be due to the Milk-Alkali Syndrome or due to ingestion of sodium bicarbonate. And in the kidneys, contraction alkalosis can also lead to gain of bicarb. I personally prefer a different scheme for classifying these etiologies based on whether the conditions are common or uncommon causes of metabolic alkaloses. Common etiologies include contraction alkalosis, diuretics, vomiting, and NG suction. Uncommon or rare etiologies include mineralocorticoid excess, hypokalemia, Milk-Alkali Syndrome, ingestion of sodium bicarb, Bartter and Gitelman syndromes, and congenital chloride diarrhea. I'm not suggesting here that hypokalemia is itself uncommon, but rather it is an uncommon cause of a clinically relevant alkalosis in the absence of an additional process. I'm going to discuss each of these etiologies one at a time, including a review of the pathophysiology. The reason to go into such detail is to provide you the background necessary to be able to predict which conditions can cause a metabolic alkalosis. It will also help you to understand how we diagnose these etiologies and what specific therapies might exist for them. One of the most common causes of a metabolic alkalosis, and certainly the most common among my own patients, is known as a contraction alkalosis. This term refers to the metabolic alkalosis that can accompany volume depletion, either actual volume depletion or the decreased effective circulating volume that can accompany diseases such as congestive heart failure. To understand the physiologic processes that drive a contraction alkalosis, I'm going to go through two key diagrams, to which I will be referring again later in this lecture. The first is a schematic of a nephron, which might look familiar from lecture 2. In the proximal convoluted tubule, we can see that bicarb and sodium reabsorption are stimulated by, among other things, a hormone called angiotensin II. In the distal tubule, through a complicated multi-step process, another hormone called aldosterone stimulates reabsorption of sodium in exchange for secretion of both potassium and hydrogen. So high levels of angiotensin II and aldosterone lead to bicarbonate reabsorption and hydrogen secretion respectively, and thus a metabolic alkalosis. However, what triggers high levels of angiotensin II and aldosterone to begin with, and how is it related to a patient's intravascular volume? The hormonal regulation of intravascular volume as it relates to acid-base balance is a very complicated topic, but I will try to simplify it as much as possible with a single slide. There are several organs involved in this process. Most prominently, of course, is the kidney. However, there are also the adrenal glands, the pituitary and hypothalamus adjacent to the base of the brain, the liver, and the lungs. For this diagram, I've colored physiologic effects in green, enzymes in blue, and hormones and pre-hormones in tan. Regulation of intravascular volume starts with low blood pressure, more accurately, low renal perfusion. Low renal perfusion stimulates secretion of an enzyme called renin from the juxtaglomerular cells in the kidney. Juxtaglomerular cells are actually specialized smooth muscle cells within the afferent arteriole, whose sole purpose is to secrete renin. Renin acts on a pre-hormone called angiotensinogen, which is initially formed in the liver to create yet another prehormone called angiotensin 1. Angiotensin 1 travels in the systemic circulation to the lungs, where the uncreatively named angiotensin converting enzyme transforms it into angiotensin 2, an active hormone. Some of angiotensin 2's actions include vasoconstriction and increased thirst. These actions make perfect sense if you remember that low renal perfusion was the trigger for this brief cascade of events. Initially separate from the renin-angiotensin system is the hypothalamic pituitary adrenal system. This begins in the hypothalamus with the release of a hormone called corticotropin-releasing hormone, or CRH, which travels locally to the anterior lobe of the pituitary gland, where it triggers release of ACTH. ACTH travels systemically to the adrenals, where it stimulates conversion of cholesterol into a variety of steroid precursors. Through a sequence of biochemical steps beyond the scope of this lecture, some of these precursors are converted into cortisol in the zona fasciculata of the adrenal cortex and into aldosterone in the zona glomerulosa. Cortisol negatively inhibits the release of CRH. The direct link between the renin-angiotensin system and the hypothalamic pituitary adrenal system is the fact that angiotensin 2, in addition to its other actions, stimulates production of aldosterone. Together, angiotensin 2 and aldosterone act on the kidney as we just saw on the prior slide of the nephron, with angiotensin 2 acting in the proximal tubule and aldosterone acting in the distal tubule and collecting duct. The combined actions in the nephron include sodium reabsorption, bicarbonate reabsorption, potassium secretion, and hydrogen secretion. In addition, cortisol actually has some activity in the nephron similar to that of aldosterone, which is only clinically relevant when cortisol levels are in great excess. This is a good place to mention that aldosterone, cortisol, and any other steroid hormone which acts on the kidney in some way to promote sodium reabsorption is known as a mineralocorticoid. I will talk more about the mineralocorticoids in a few minutes. One of the net results of all this, of course, is a metabolic alkalosis. In addition, the sodium reabsorption promotes water reabsorption, which in turn increases blood pressure and thus renal perfusion. High renal perfusion is responsible for negative feedback on the juxtaglomerular cells and subsequent decreased renin secretion. Although a complete discussion of the regulation of intravascular volume would also include things such as ADH, ANP, and other hormones, this diagram is sufficient for an understanding of the generation of a contraction alkalosis. The next most common etiology of the metabolic alkalosis is the use of diuretics. Here is the nephron once again with the proximal convoluted tubule, loop of Henle, early distal tubule, and the collecting duct. I'm going to add in one additional segment, the thick ascending limb, which I haven't previously mentioned in this course. To understand the role of diuretics in the kidney, I first must mention two important transporters, which are transmembrane proteins on the luminal side of the cells lining the nephron. These transporters are responsible for movement of solutes from the tubule lumen back into the intracellular space, from which they will eventually make their way back into the systemic circulation. The first of these transporters is in the thick ascending limb, where it leads to the simultaneous reabsorption of one sodium ion, one potassium ion, and two chloride ions. The second transporter is in the early distal tubule, where it leads to simultaneous reabsorption of one sodium and one chloride ion. There are two classes of diuretics that lead to metabolic alkalosis. The first are called loop diuretics. These include furosemide or Lasix, bumetanide or Bumex, torsemide, and ethacrynic acid. Loop diuretics inhibit the cotransporter in the thick ascending limb, which prevents sodium reabsorption and thus leads to an increased excretion of water. The second relevant class of diuretics is the thiazide diuretics. These include hydrochlorothiazide, chlorothiazide, also known as diuryl, chlorthalidone, and metolazone. Thiazides act by inhibiting this cotransporter. Loop and thiazide diuretics can lead to a metabolic alkalosis through two mechanisms. First, dehydration from excessive diuresis can trigger a contraction alkalosis. Alternatively, blockage of sodium reabsorption proximally will lead to increased delivery of sodium to the collecting duct. This will shift the electrochemical balance where sodium is reabsorbed in exchange for secretion of potassium and hydrogen. Thus, diuretics can lead to this effect even if they don't trigger increased levels of aldosterone. Next is vomiting and nasogastric suction. These two have identical effects on a person's physiology and can lead to a metabolic alkalosis as a consequence of volume depletion and a secondary contraction alkalosis, as well as direct loss of hydrogen in gastric fluids rich in hydrochloric acid. The effect of vomiting and NG suction really is that straightforward. The next etiology is mineralocorticoid excess, and this is a bit more complicated. A state of mineralocorticoid excess is suggested by the constellation of hypertension, hypokalemia, and a metabolic alkalosis. So here is this chart again, showing how hormones regulate intravascular volume. Most forms of mineralocorticoid excess are due to defects here in the hypothalamic pituitary adrenal axis. However, a very similar state can develop on account of excess levels of renin as well. When I think about the specific etiologies of mineralocorticoid excess, I think primarily of two major categories. First is hyperaldosteronism, in which, as the name implies, an elevated aldosterone level is the predominant problem. The other category is Cushing's syndrome, where either an elevated cortisol level or the presence of an exogenous steroid is the predominant problem. For those of you curious about medical history, Cushing's syndrome is named not after an endocrinologist as most assume, but rather an American named Harvey Cushing, who was actually a neurosurgeon and who had described the syndrome in the context of a malfunctioning pituitary gland. Cushing led quite an interesting life, among which was attending to the mortally wounded son of one of his heroes, William Osler, in a Flemish battlefield during World War I. Getting back to metabolic alkalosis, hyperaldosteronism can in turn be broken down into two subcategories. The first is when elevated aldosterone levels occur on their own, in the absence of another triggering hormone abnormality. This is termed primary hyperaldosteronism. Primary hyperaldosteronism is usually caused either by bilateral adrenal hyperplasia or an adrenal adenoma secreting aldosterone. This latter condition is called Conn syndrome after Jerome Conn, an American endocrinologist from the University of Michigan. Other more rare causes of primary hyperaldosteronism include an aldosterone-secreting adrenal carcinoma, a rare genetic disorder called glucocorticoid remedial aldosteronism, in which exogenous corticoids such as prednisone will paradoxically correct hypertension, and finally a number of rare forms of congenital adrenal hyperplasia, the details of which are fascinating to pediatric endocrinologists, but which are well beyond the scope of this talk. In addition to primary hyperaldosteronism, a nearly identical syndrome can be caused by an inappropriately elevated level of renin, a condition known as secondary hyperaldosteronism. High renin results in high angiotensin II, which in turn stimulates excess production of aldosterone. High renin levels are usually due to stenosis of one or both of the adrenal arteries by either atherosclerosis or fibromuscular dysplasia. Fibromuscular dysplasia is an uncommon but probably under-recognized cause of refractory hypertension presenting under the age of 40 with a slight female predominance. Renin-secreting tumors of the juxtaglomerular apparatus have also been described but are quite rare. Moving on to Cushing's syndrome, this can be caused at any step along the hypothalamic pituitary adrenal axis. So the first cause is an elevated level of CRH, caused by a CRH-producing tumor, which for some reason is best described in bronchial carcinoid tumors, which are quite rare. The next step along the axis is an elevated ACTH. When caused by an ACTH-secreting pituitary adenoma, it's called Cushing's disease. Elevated ACTH can also be caused by ectopic production by a tumor, usually small cell lung cancer. Next, an elevated cortisol can be the result of an adrenal adenoma, a cortisol-secreting adrenal carcinoma, or from chronic licorice ingestion. Licorice contains glycyrrhetinic acid, a natural steroid, that inhibits an enzyme normally responsible converting cortisol into cortisone, which has much less mineralocorticoid activity. A synthetic form of glycyrrhetinic acid known as carbonoxolone is occasionally used in the UK for various esophageal disorders and has hyperaldosteronism as a side effect. The final cause of Cushing's syndrome is exogenous steroids, usually prednisone. One final miscellaneous cause of apparent mineralocorticoid excess is Liddle syndrome, which is a rare autosomal dominant disorder in which there is excess sodium reabsorption and potassium secretion in the collecting duct. Hypokalemia is the next general etiology of a metabolic alkalosis. Hypokalemia leads to a metabolic alkalosis through several mechanisms. First, in the presence of hypokalemia, there is a shift of potassium ions from the intracellular space to the extracellular space in exchange for a shift of hydrogen from the extracellular space to the intracellular space. In addition, within the nephron, hypokalemia is a stimulus for the reabsorption of bicarbonate in the proximal tubule and for secretion of hydrogen in the collecting duct. Milk-Alkali Syndrome. This syndrome consists of the constellation of hypercalcemia, metabolic alkalosis, and renal insufficiency. It is associated with the ingestion of a large amount of calcium and absorbable alkali. It was originally described in patients consuming large quantities of milk and sodium bicarbonate for treatment of peptic ulcer disease, but currently it is more common in older women taking calcium supplements for prevention of osteoporosis. Milk-Alkali Syndrome can also be seen in Oceania and the Far East, where consumption of betel nut is sometimes accompanied with either calcium carbonate or calcium hydroxide. Although the mechanism of pathogenesis superficially seems obvious, various attempts to explain the complete pathophysiology of Milk-Alkali Syndrome have not been fully convincing, and a definitive description of the disease remains elusive. Bartter and Gitelman syndromes are autosomal recessive disorders of the membrane transporters in the nephron. Their shared features include a metabolic alkalosis, hypokalemia, high renin and aldosterone levels, and a lack of hypertension. Distinguishing features between the two include the following. Patients with Bartter syndrome frequently have mental and growth retardation and hypercalciuria. It usually presents in young childhood and is exceptionally rare. Patients with Gitelman syndrome have a predominant complaint of muscle cramps and are hypocalciuric. Gitelman syndrome presents in adolescence and is very rare, but not as much so as Bartter. To understand exactly how these syndromes work, here is a picture of the nephron again, with our tubular transport proteins drawn in. You will recall that the target of loop diuretics is a sodium-potassium chloride transporter in the thick ascending limb. In Bartter syndrome, this is the affected protein. Therefore, Bartter syndrome biochemically mimics treatment with loop diuretics. The thiazide diuretics block the sodium chloride transporter in the early distal tubule, and this is where the problem is with Gitelman syndrome, which therefore mimics treatment with a thiazide. The last topic I would like to address in this lecture is how to approach a metabolic alkalosis and establish a diagnosis. The first step is to assess volume status. If it is low, the history will almost always be sufficient to explain the situation, as the patient will have either an obvious contraction alkalosis from primary dehydration, diuretics, vomiting, or NG suction. If none of those are apparent, and the patient is in the appropriate age demographic, you may be dealing with one of those rare cases of Bartter or Gitelman syndromes. On the other hand, if the volume status is either normal or high, the next step is to assess the blood pressure and serum potassium level. If blood pressure is normal and potassium is low, then hypokalemia is in itself the likely cause of the alkalosis. Of course, hypokalemia has its own differential diagnosis, which I won't get into here. If the blood pressure and potassium are both normal, then I would consider either the administration of exogenous alkali, such as sodium bicarbonate tablets, or Milk-Alkali Syndrome. Finally, if the patient has significant hypertension, then the condition to worry about is Mineralocorticoid Excess. At that point, renin and aldosterone levels should be checked. The appropriate means of measurement and interpretation of renin and aldosterone is a complicated topic that I won't have time to get into in any detail in this lecture, but the basic interpretation can be deduced from the aforementioned discussion of the body's hormonal regulation of intravascular volume. Therefore, a high aldosterone and low renin level suggests primary hyperaldosteronism. A high aldosterone and a high renin suggest secondary hyperaldosteronism. A relatively normal aldosterone and normal renin suggest Cushing's syndrome. And finally, low aldosterone and low renin suggest an extra hormonal cause of the apparent mineralocorticoid excess, such as exogenous steroids, licorice ingestion, and the rare Liddle syndrome. That does it for the differential diagnosis of a metabolic alkalosis. The next two lectures will cover primary respiratory disorders.